All right, everyone. Now we'd like to welcome Li-Chi Long and Joseph Lockman for our keynote presentation. Li-Chi Long is the Senior Policy Advocate at Northwest Health Law Advocates. With extensive experience in public health, higher education, international human rights, youth engagement, and reproductive justice, she has worked in both New York City and Washington State. Li-Chi has held key roles at nonprofits, including directing the NYCLU's Teen Health Initiative and contributing to the launch of 2 accountable communities of health in Washington. In 2023, Li-Chi was honored with the Health Justice Advocate of the Year Award for Families USA for her work on immigrant health expansion in Washington. Joseph Lockman is the Policy Manager at Asian Counseling and Referral Service in Seattle, which serves more than 30,000 community members annually in more than 30 languages. His policy work focuses on socioeconomic equity, voting justice, health equity, and environmental justice affecting Asian and Pacific Islander immigrants, refugees, and other communities of color. Outside of his role at ACRS, Joseph is a part-time yoga teacher and is pursuing a Master of Public Health at the University of Washington. So right now we're going to welcome Li-Chi to the stage, and Joseph will join us a little bit later.
Good morning. Thank you so much for taking the time to learn with us about equitable health coverage and for inviting us to share. My name is Li-Chi Liang. My first name is Li-Chi, and I'm honored to be your keynote speaker along with Joseph. I have short black hair and glasses. I'm wearing a purple jacket with a black and purple scarf. As you all know, behavioral health is a key component of health, and health coverage often determines access. For 25 years, Northwest Health Law Advocates, or NOLA, has worked to achieve a healthcare system in which all Washingtonians receive quality, affordable healthcare, and to advance health as a human right. Should note, I'm not a lawyer. This is not legal advice. This is an overview of Washington's recent advancements to address health coverage disparities for Washingtonians who have been structurally excluded from our safety net. Next slide. As you can see from this timeline, starting in 1790, the U.S. limited citizenship to, quote, free white persons. Open borders, however, didn't end until almost a century later, when the United States passed the Page Act in 1875. That law explicitly targeted women from China based on racist stereotypes. Congress followed up 7 years later with the first and only ban on a specific group, the Chinese Exclusion Act, followed by tropes which are familiar: laws requiring English, banning individuals with disabilities, banning children without parents, and also stripping citizenship from women who married foreigners. In 1921, immigration was limited to 3% of current residents from that country. It is also important to note that in 1898, the Supreme Court decided in U.S. versus Wong Kim Ark that despite these laws, they did not prevent the children of Chinese immigrants born in the U.S. from acquiring birthright citizenship. Next slide, please. So in 1924, Congress shrank the total number of visas to 164,000. That was an 80% drop from 1914. They also established per country cap allocations. 82% of all available visas went to Western and Northern European countries. An additional 14% went to Eastern and Southern European countries. For you of those who haven't done the math in your head, that left a miserly 4% to the remaining Eastern Hemisphere, Asia and Africa. There were no caps for people from North or South American countries. While, after almost 70 years, the Chinese Exclusion Act was finally repealed, percentage caps remained, which meant that was based on residence and decades of barring entry. Race wasn't formally removed as a grounds for exclusion until 1952. In 1986, we did see legalization for unauthorized immigrants, And then a decade later, we saw the introduction of penalties for undocumented immigrants who stayed in the US for a statutorily defined period of time. The bottom line, more people were deportable, fewer people could be legalized, and the 5-year bar was established. Which brings us to the next slide. As you can see, the vast majority of people from the United States without federal immigration status are visible minorities. This is not an accident. This is the predictable result of laws that create an immigration system built on racist assumptions. This pie chart shows the regions of origin for undocumented immigrants in the US from 2022. We can move to the next slide. So things look a little bit different in Washington. While the vast majority of undocumented Washingtonians are also visible minorities, this picture doesn't match the assumptions many people make. The largest communities of undocumented Washingtonians actually come from Asia and the Pacific Islands. It's worth remembering that undocumented communities and people of color in our state are often different than expectations. Addressing disparities require that we understand that policies have consequences. They shape who we are, and they reflect what we value, who we value, and it's important to keep in mind that we collectively have the power to improve things. Next slide. This slide illustrates that advocacy requires persistence. Back in the 80s, Washington was a leader in health coverage. Some of you may recall we had a program for low-income people regardless of immigration status called Basic Health. In the 2000s, we extended coverage to all low-income kids. Unfortunately, with the Great Recession, that ended Basic Health in the lead up to the Affordable Care Act. Since that time, advocates have slowly worked to build back coverage for adults. We expanded family planning regardless of immigration status. More recently, we expanded postpartum coverage for 12 months regardless of status. While progress takes time, I'm really pleased that we can share more about our recent progress. Next slide. So the pandemic really tragically illustrated that we are all healthier when everyone has access to medical care. In 2021, state legislators took important steps, directing state agencies to authorize state subsidies, also beginning the groundbreaking 1332 waiver work. We'll speak more about that in a second, and exploring a state Medicaid equivalent program for undocumented adults. I need to say a big thank you to the hundreds of individuals and organizations that sent supportive comments during our 1332 application process. We collaborated to gather over 400 supportive comments during the state period and hundreds more during the federal period. This really was a group effort. And last year, the legislature invested state funds in coverage for all Washingtonians, which moves us forward. Next slide. So ACA did a lot of great things. It ended discrimination for 135 million people with pre-existing conditions in the individual market. It provided federal funding for marketplaces and children's health insurance. It required insurance companies to issue rebates when they overcharge. However, it also included a poison pill. It extracted a congressional compromise which excluded people without federal immigration status from using their own money to buy health coverage. The good news is Section 1332 of the ACA allows states to apply for what's called a state innovation waiver, also called a Section 1332 waiver, great names, to pursue innovative strategies to provide residents with access to high quality, affordable health insurance while retaining the basic protections of the ACA for everyone, which you can see on this slide. The vast majority of 1332 waivers are for reinsurance, which means minimizing risk for insurance companies. However, in Washington, we took a more simple approach that helps address individual risk. We sought and secured permission to let all Washingtonians use their own money to buy health insurance. Next slide, please. So currently, all Washingtonians up to 250% of the federal poverty level can get up to $250 a month in state assistance. While we're proud that Washington is the first state to offer both access to our state exchange and a Medicaid-like program, we've learned some important lessons and identify ways we could do better moving forward. So privacy is still a concern. Affordability is still a barrier, and translation doesn't actually equal outreach. Next slide, please. So immigrant communities have good reason to be concerned about privacy. The Health Benefit Exchange understood this and negotiated specific protections in our state waiver to address this. Fortunately, we still hear from community-based organizations and advocates that many people are worried about privacy, and that continues to be a barrier. Fears instilled by the last administration still haunt people. Next slide, please. The good news is that Washington has built on years of progress. The programs on the left are things that already existed. I do want to take a minute to point out that few people realize charity care could benefit half the people in Washington. Half of us are eligible for free or reduced care at hospitals. Keep that in mind if you have to go. However, affordability continues to be a challenge. Washington's taking steps to address affordability include helping those with the fewest resources through the new Medicaid-like program, Apple Health Expansion. I want to take a moment to emphasize just how important behavioral health treatment is for Apple Health populations. The most common conditions among Medicaid clients were in the category of mental disorders. The mental health expenditures for Washington's Medicaid program were $1.3 billion in 2022. That's nearly 3 times the second highest category. Next slide, please. So, how many people can feel the impact of this year's improvements? Well, everyone in Washington can shop for health coverage on HealthPlanFinder. That's a gain for everyone on this pot. Over 100,000 of our neighbors, friends, and families. For those who are uninsured and undocumented, about 2/3 are eligible for those state-sponsored savings, Cascade Care savings. That's the up to $250 a month and help with premiums, the people in the big blue slices. About 1/3 are eligible for Apple Health Expansion, that new Medicaid-like program. I want to note that Deferred Action for Childhood Arrival recipients are considered undocumented for now. The good news is that 24,000 of the newly eligible population, or nearly 1 in 4 people on this slide, verified their identity during open enrollment and shopped for plans. The less good news is only about 2,200 initially signed up for health insurance, which brings us to that second lesson. Affordability is still very much a barrier. And the third of folks who are undocumented and uninsured and eligible for the new state program might be eligible, but funding is capped. And we're all looking at a pretty tight budget next year. So we need to work really hard to protect what we have and hopefully do better. Next slide. So just to recap, people can still apply to be considered for that Medicaid-like program despite capped funding. Please let people know. People can shop for plans and sign up to be considered on HealthPlanFinder year-round if they're between 19 and 64. People 65 and older can shop for coverage on HealthPlanFinder, but they have to use Washington Connection to sign up to be considered for space if it becomes available under Apple Health Expansion. Next slide, please. So while we're proud of the progress we've made, and standardized plans help, incentivized enrollment helps, there are still pretty significant barriers, as you can see on this slide. These barriers are greater for older adults because premiums increase with age, and currently Washington has a flat cap on state subsidies. This should improve for DACA recipients in November if they want coverage starting this December. They'll move from the right-hand column to the middle column because they will begin qualifying for federal premium subsidies, which means folks at lower incomes might have $0 premiums. Next slide, please. So it's pretty obvious that translation is essential, which is why the Health Benefit Exchange eventually made materials available in 25 languages. They hired an ad firm to co-create materials in Spanish, Chinese, Vietnamese, and Russian due to the large number of limited English populations that speak those languages. However, they opted to exclude community-based organizations from Chinese, Vietnamese, and Russian communities from receiving funding for trusted messengers. That wasn't true for CBOs that serve Spanish communities. We'll see the results on the next slide. Translation doesn't mean outreach. That's the third lesson. In Washington, there are about 255,000 Spanish speakers who speak English less than very well. Almost 4% engaged with the exchange during open enrollment. By contrast, about 60,000 Washingtonians speak a dialect of Chinese and speak English less than very well. 0.086 engaged with HealthPlanFinder. Of the 40,000 Russian speakers, 0.057% engaged during open enrollment. And we don't even have a percentage for Vietnamese speakers because there were less than 10 requests. By comparison, over 5% of Portuguese speakers with limited English engaged with the exchange during open enrollment. This isn't about small numbers. This is about how and who the Health Benefit Exchange chooses to prioritize. Next slide, please. So we did a lot of work at Northwest Health Law Advocates, partnering with community-based organizations to try to fill some gaps. We got materials out early because CBO said we really need time to spread the word. In June, we updated these materials, as you can see, because Apple Health Expansion is a great program, but there was no outreach budget for the Healthcare Authority to spread the word until July 1st, when the program actually started. So I think we can all collaborate to do better and let everyone know applying for health coverage isn't a public charge. Next slide, please. So many immigrants prefer a language other than English. Also, the proportion of people who prefer another language really varies. While there are differences in Dominican Spanish versus Cuban Spanish, Spanish is a shared language. There's a more dramatic difference in what proportion of Spanish speakers have limited English, depending on their country of origin. About 13% of Ecuadorians fall into that category versus 41% of Hondurans when we look at the country as a whole. By contrast, immigrants from Asia speak dozens of languages. And while only 15% of South Asians and 18% of Samoans report speaking English less than very well, nearly half of people who prefer Vietnamese in Washington are in that category. Language matters, and language access matters. only 25% of Asian Americans received mental health services, compared with 52% of non-Hispanic white populations. Suicide was the leading cause of death among Asian Americans and Pacific Islanders, 10 to 19. We don't know how many had limited English, but I think we all know it's hard to get behavioral health when you do speak English. The Latino Community Fund did a landscape scan of Spanish-speaking immigrants in Washington and found half had trouble getting care due to language barriers. We can infer it's exponentially harder when you speak a language of lesser diffusion, which is why I'm pleased that Joseph is joining us from ACRS now.
Hello, and thank you again, Lichi, for passing it off to me. Again, my name is Joseph Shoji Lockman. I'm the policy manager at Asian Counseling and Referral Service. I use he, him, his pronouns. And just noting that, so I'm a mixed race Asian American man with glasses, short brown hair, wearing a white and blue hooded sweatshirt right now. So just to kind of start from there, well, that's the slide forward. Great, thank you. So I'm going to just offer here just a quick overview of Asian Counseling Referral Service, the organization where I've been working for the last 7 years, and talk a little bit about our agency's work as well as our involvement with the Apple Health expansion and improving healthcare access for our immigrant and refugee community members. So going to the next slide. Just a brief background on Asian Counseling and Referral Service. I know some folks here are familiar with our work, but for folks who are not, Asian Counseling and Referral Service was founded in 1973, and it really represented a response to the lack of culturally appropriate and linguistically accessible care for Asian American and Native Hawaiian / Pacific Islander communities, especially immigrants and refugees whose first language is not English. We started in the Chinatown International District, but over time, over the last 50 years, have expanded the number of employees, number of programs, number of folks that we're serving, eventually expanded to, in 2008, to the building that you see in this photo here, which is where our main office is in the Rainier Valley area along Martin Luther King Jr. Way South. The next slide. And just a little bit about the staff and our services that we provide today. We've just gone beyond our 50 years in operation. Staff has expanded from a very modest group of folks and then previously in the CID office, all the way to over 300 people now, speaking over 40 different languages and providing a wide variety of social services. So this includes our immigration and citizenship assistance, language and job skills, also helping with things like digital literacy for folks trying to learn how to navigate modern technology, nutrition and exercise. You can actually see in the photo here, this is our 3/4 size basketball gym where we have opportunities for exercise. Hello, this is my cat Josie. She's walking through. We also have opportunities for exercise like badminton, pickleball, ping pong, and other sports in the gym, as well as providing nutritious and culturally appropriate meals for many of the seniors who come to our building for both socializing and other services, but also getting important staple foods and their diet. Of course, we have mental health counseling, which is one of the main services that we provide. Of course, in language for folks, regardless of what language they're coming in speaking. We have opportunities for youth to help develop their leadership skills and build confidence. We also have recovery services for folks who are struggling with either substance abuse or problem gambling. And then last but not least, civic engagement is something that we see as another social service that we're providing so that folks feel engaged in their communities, feel like their voice matters, feel like they have ways to actually impact the systems that are already impacting them. So as part of this, it's been important that we engage folks on their experience with things like healthcare. My cat saying hello again. And it's been a really important opportunity again, though, to hear what folks' experiences are like, both with the healthcare system, whether they're undocumented or if they're under the 5-year bar, or if they're citizens, or if they're trying to help family members. And so that's an area where we've really found it's been important for us to hear from folks, hear about their experiences, and really try to relay that to the agencies and make sure that they're being responsive to community concerns. All right, we'll advance to the next slide now. Just a note about ACRS's mental health services here. So again, it's one of the main services that we provide and can really be seen as addressing a gap back in the 1970s that was very apparent. Mental health and primary care services, we saw a gap in both areas, which is something really you could see as resulting in Asian Counseling Referral Service, as well as we consider our sister agency, International Community Health Services, multiple organizations that arose at the same time in response to these needs. So really at the core of our approach to providing behavioral health services is making sure that we're taking this holistic approach that's meeting the cultural, linguistic needs of community members, really helping to care for their mental and physical health. So we have case management, individual group family therapy, psychiatric evaluation and medication management, supported employment. We actually have a really cool concept where we have a cafe that's inside of our ACRS building where clients are able to actually work on developing job skills and actually serving coffee, keeping the staff caffeinated, but having the opportunity to do this with their case manager present so that they're able to develop these skills in a very safe and supportive environment. We also provide some assistance with securing housing, wellness and day activity programs like I showed in the previous slide, as well as some non-Western medical practices such as acupuncture, again, responding to the cultural needs and desires of the folks who are coming to us for services. Next slide, please. So talking a bit specifically with healthcare access. So ACRS, we've been really honored to have opportunities to work with important community partner organizations, especially in light of the Apple Health expansion, and that's including organizations like Indian American Community Services, the Korean Community Service Center, the Pacific Islander Health Board, and the Filipino Community of Seattle, many other wonderful organizations. And we've had conversations with staff at some other organizations, in addition to talking to our own staff. And as much as possible, always honoring the privacy, confidentiality of community members, especially on sensitive topics like immigration status and healthcare issues, but making sure that as much as possible, we're relaying their concerns, even if just anonymously, to the healthcare authority, in terms of things like, just being able to access care that meets their linguistic and cultural needs, and also just addressing more universal issues like, actually being able to get health insurance, or affordability issues. And as Leach had alluded to earlier, for years, we've been dealing with concerns of the idea of public charge that's been, really on folks' minds for years, especially during previous administration when, the rules about public charge were, really making headlines. There were also concerns about the idea that this might result in, compromising, other ways that it could compromise their ability to change their immigration status. Scams have also been a concern. Some also just find the process of signing up to be, cumbersome, just to the point that, they feel like they can't complete it. And it's also important to remember too that, Lychee showed some important data looking at the, the use of, the materials in other languages. And you see actually, even when those materials were available, that didn't necessarily mean that, they were going to be the most usable for our community members. And at the same time, there are also just, as I mentioned, 40 plus languages that our staff at ACRS are providing services for at any given time. And for a lot of those folks, there's actually quite a few, and then maybe they speak a language that most folks have never even heard of. So sometimes that just means that, we really have to find ways to go above and beyond to make sure that everyone feels included in these kinds of programs. Folks also worry about, costs that, they weren't aware of because of, issues like when they signed up. I'm also just making sure I monitor the chat here, but just noting that Cafe Hope was mentioned in the chat here. Cafe Hope is our wonderful first floor cafe at ACRS. I'd encourage folks to come visit, maybe like a Thursday morning. Again, provides supportive employment. So folks who are learning job skills can actually come, and actually learn to be a barista, provide caffeinated drinks to our staff, tea, coffee, in a way that they're able to develop those job skills while also having, supportive, just guidance from their case manager, in a way, again, they're able to, make use of the skills that they're actually learning through their employment program at ACRS. And again, just being a safe and, respectful environment. And again, it's an important part of, how we try to provide holistic care for the folks who are coming to us and help them feel integrated into their community and actually feel, safe coming forward with their concerns about anything, whether it's, their, job skills or, other needs like mental health or primary care or, just accessing health insurance. Let's advance the slide again. So I did note some pretty concerning challenges that folks are, dealing with in this situation, but I also want to note, some important success that we've seen. Again, we've been collaborating with a lot of great organizations who've also been helping us gather feedback on the Apple Health expansion. Another one I'd forgotten to mention is Chinese Information and Service Center. Thanks, Josie, for the third cameo. So in terms of success stories, signups from Asian and Native Hawaiian and Pacific Islander communities were a lot smaller than we had hoped, obviously. And for folks who did sign up, though, they really did tell us how much this mattered to them, and that, even if, one person signed up and benefited from this, that, again, we think of that as a huge success in itself for that person. Community members, in terms of some sentiments that we heard, displayed surprise that they would even be eligible for a program like this. Again, because I think we're really trying to change, the culture of the idea of, who should be part of the social safety net. Yes, my coworker is rude, but absolutely adorable. Thank you. So there are community members, many who actually, really feel like they're resigned to going without health coverage, and they've become accustomed to this for years and have, they kind of expect to be excluded from important benefits. But, we're finding ways to change that in our state. And for some folks, even if they are eligible, the costs continue to be a major barrier regardless of their, immigration status. But so for folks, finding out that there actually was an option that was both accessible and affordable, we had some folks that were really just excited, because it meant that it was going to be, the first time in years maybe that they were able to actually see a doctor. Somebody just told us, this is unexpected. I'm happy about this result, so I can go to see the doctors. That was actually a comment from a Chinese immigrant community member. We actually also, it was a wonderful surprise, but one of my wonderful classmates in my master's in public health program at University of Washington relayed that their mother was actually able to access health insurance for the first time because of the expansion, and actually, finally got to see a doctor, which is, again, just a great reminder of, the impact that this program is having, even if the cap, is still frustrating. We're really, we're really inspired by this, and, we're looking to keep making progress on this and making sure that our folks are able to, both access care, but also, have it be affordable and, actually accessible, in their language. With that, I'll hand it back over, and I think we'll have a little time for some question and answer. Thank you.
All right. Thank you for that. So we have a good amount of questions in the chat, so let's just hop right into it. The first question is, how can we do better reassuring clients concerned about accessing healthcare due to immigration status and being reported to ICE?
Yes, that is a great question. So I think first, it's important to spread the word that the Health Benefit Exchange did take steps to make sure no personally identifying information is actually going to the federal government. So please share that with your clients. The sort of ancillary concern that often gets raised in this context is, what about public charge? And Northwest Health Law Advocates actually charge actually applies to, and that applying for health coverage does not count as a public charge. That's one of the resources that should be available with this session, and I can also drop a link in chat if that's helpful.
Great, thank you. The next question is, insurance always seems like a huge beast that just exists in the healthcare landscape. What can we do as healthcare and public health professionals? What can we do as healthcare and public health professionals to ease the current burdens and change the future?
Great question. I think the good news is that about 12,000 Washingtonians now have access to Apple Health Expansion, which means they have access to free healthcare with no premiums, no cost shares, and they get care under the auspices of a managed care organization. So there should be additional care coordination and support. The bad news is that the vast majority of space is filled in less than 2 days. And we know over 7,700 people have been denied due to that cap. So I would say, please tell your elected officials we need more funds to promote affordable access, more space in the Apple Health Expansion Program, more equitable support for people between 138% of the federal poverty level and 250% of the federal poverty level who want to purchase qualified health plans, but right now can't. Please vote for people who support access to health coverage. We've got some really important elections coming up and some really important initiatives coming up. And I think it's really vital to understand how important civic engagement is.
Absolutely. What specific programs or initiatives have been most effective in supporting language acquisition and inclusion for immigrant communities in Washington?
I'm actually going to ask our moderator to bring back up that last pie chart slide that we didn't get to. It's right before the pink ACRS slide. So if we go backwards. This one. Sorry about the snafu. So I think it's really important to understand that third lesson, that outreach and access are not the same thing, and that language preference is really key. It's just really challenging to communicate in a language that you're not comfortable in. And it's also important to keep in mind that how you distribute resources has an impact. As you can see on the slide, of the people who were able to enroll in the Apple Health Expansion Medicaid-like program, almost 80% prefer Spanish, which is great for Spanish speakers. However, you might think back to that prior pie chart about the percentage of undocumented communities in Washington. 43% come from countries in Asia or the Pacific Islands. But when you look at what percentage of people preferred those languages, it's less than 1% when you add it up. And I think that points to a really grotesque disparity that was the clear result of a policy decision made by the Health Benefit Authority. So I think we need to ask ourselves, and we need to ask agencies, how they can do better about distributing resources more proportionally.
The next question is, what is public charge?
Great question. So some people who apply for a green card, that's lawful permanent resident status, or a visa to enter the United States, need to pass a public charge test. It basically looks at whether they're likely to depend primarily on government support. So immigration officials look at all of a person's circumstance to consider that. And they look at specific types of benefits that have been used in the past. So the public charge test is something that comes up mainly for people applying for green card status through a family visa petition. Many people are not subject to a public charge test and do not have to worry about it.
Got it. Next question. Do you have any tips for navigating health insurance that does not cover behavioral health care? I have a client that's on Medicare Dual Advantage plan, and somehow neither option cover MH or SUD treatment.
So healthcare is very complex, and Medicaid Advantage is a complicating factor. So I will say, let's connect offline, because I'm going to refer you to a colleague.
Great. Okay, the next question. Does Apple Health cover holistic wellness practitioners that are rooted in specific cultural traditions?
So Apple Health is run by managed care organizations. The Apple Health Expansion Program, like other Apple Health programs, has different managed care organizations that provide benefits, and there are some differences between the different MCOs. All Apple Health programs, all Apple Health Expansion managed care organizations do cover behavioral health, but I think if you have specific questions about specific cultural traditions, that would really depend on which tradition and which MCO a person is receiving coverage through.
Please review expanded Medicaid.
Okay, so the Apple Health Expansion Program is a program for folks who do not have access to federal premium tax credits. Basically, that means people who are undocumented. And the Apple Health Expansion Program does cover all of the essential benefits. It does cover behavioral health. It launched on July 1st of this year. People were able to start applying on June 20th. And as I mentioned, the vast majority of the space in the program filled in less than 2 days. However, people can still apply to be considered if space becomes available. And people can do that through HealthPlanFinder if they're between the ages of 19 and 64, and through Washington Connection if they're 65 or older. So it's full scope Medicaid. It's coverage very much like Apple Health for kids or Apple Health for other adults. Anyone who's been on pregnancy related Apple Health coverage is full scope Medicaid. Like, you need to see your primary care physician, if you need prescriptions, if you need to see the dentist, all that is part of the Apple Health Expansion benefit package.
Next question is, how can we continue to implement and address racial disparities, to access care? What are some policies that can further add protection for Asian and NHPI communities? What are some ongoing issues that you come in contact within the agency the most?
I do think language access issues continue to be a significant barrier. I think we have an incredibly diverse population in Washington, which is fantastic. But the reality is that the services we provide and service providers don't necessarily match the diversity of our communities, which is why places like ACRS are so important. I don't know if you want to jump in here, Joseph.
Could you repeat that question? I was trying to just answer another one in the chat.
Sure. And can we get it on the screen again as well? How can we continue to implement and address racial disparities to access care? What are some policies that can further add protection for Asian and NHPI communities? What are some ongoing issues that you come in contact with in the agency the most?
I think Leachy already hit a bit of it in the slides and in just your answer right now. I really advocated for having strong usage of what we call the trusted messenger model. Sometimes you hear like promotores used as a term for this, but just really the idea that our community members do best when they're when the outreach to them is done really by the organizations who they already know and they trust. And that's been used, for example, like in outreach for the census and for other programs. Our community members, they really can be afraid to enroll in some programs or make use of resources, but when it's, somebody they trust, like their case manager, somebody in their life who they trust, they're much more, I think, open to, trying to sign up for programs that they might otherwise be, where they have some fear or some, apprehension, and making sure that, the folks at the agencies and legislators, who are, designing and implementing these programs are actually hearing, directly from community members. So always finding ways to bridge, bridge those gaps. I really driving home that lesson that, Leachy talked about too, though, that just having resources, in one particular language does not make them helpful unless they're actually helping people. So I think those are some of the major elements there.
And I'd like to jump in with one additional thought. So one of the differences between Apple Health Expansion and other Apple Health programs is that the language access services look different. So there are healthcare authority administered language access services. And in the Apple Health Expansion population, that responsibility has been shifted entirely to managed care organizations. But we don't have a good sense of how this experiment is going, in part because it's only been a couple of months, but in part because we don't yet have transparency about what the quality metrics are, how the healthcare authority is going to figure out that people are actually getting the services they need. We also know that language access is really challenging in Washington for anyone who doesn't speak English. And that's even true for Spanish speakers. So if you speak a language of even lesser diffusion, it's just exponentially more challenging. So, while we have great laws on the books, while there are civil rights protections about language access, I think we all know the reality of implementation is system doesn't we don't always fulfill the promise of the law. And we need to be really cognizant of continuing to advocate for better adherence with the aspirations we do have.
Absolutely. The next question, Medicaid HPs are required to do a performance improvement project for our new population we serve, AHE. Would it be possible to meet with you, Joseph, to gather the voice of the community and voice of the customer to help build my PIP?
Yes, of course.
All right. Well, you guys will make that happen. Does anyone know if they are going to have more spots open for the expanded care next year?
I don't think anyone knows that yet. What we do know is that there are over 7,700 people who didn't get a spot due to the enrollment cap. We know that funding limitation is a real barrier. We know that elected officials appreciate hearing from their constituents. So if you think this is a priority, please contact your elected official and let them know that you support having more space and more affordability in this program, that it is a priority to you as a voter and or constituent. I think that, again, it's really important to keep in mind that Washington is facing a fairly significant budget deficit, and that we appreciate that the healthcare authority said expanding the Apple Health Expansion program is one of their top priorities. We also know that budget conversations are hard and there are a lot of competing priorities, and that the initiatives have an impact on how big that hole is. So I would say we don't know how many spots, but we do know that there are things you can do to improve the likelihood that there are as many and hopefully more spaces available. And invite you to get in touch with either Northwest Health Law Advocates or ACRS if you'd like to learn more about getting involved.
All right, I see that Joseph answered one of these questions in the chat, so I'll go to the last question during our last minute because it's about time for us to wrap up. How is the CCB? Do we have an answer for this one? All right. Well, it is 9:10, so I'm going to wrap it up. And also just reiterate what you said multiple times: vote, contact your officials so we can make the change that needs to happen. But thank you so much for this keynote. This was wonderful. I see a lot of hearts and hand clap emojis coming on the screen. So I know that everyone enjoyed this. Thank you so much for your time today. So now we're